Hello, everyone. Thank you for joining us today for our webinar entitled Staged for Success, Medicaid Promoting Interoperability Stage 3 in 2020. Today's presenter is Bruce Mackey, MCEDA's Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will be posting the presentation slides and a recording of today's webinar on our website, www.mceda.org. Also, the presentation slides, as well as a couple of other resources Bruce will reference, are currently available for download in the handout section of your GoToWebinar interface. Today, Bruce will discuss the Medicaid Promoting Interoperability Program, reviewing updated eligibility criteria and 2020 program requirements. From there, Bruce will discuss this year's objectives and measures, taking a deeper dive into the Health Information Exchange and public health objectives, as well as reviewing the state requirements for electronic clinical quality measure reporting. Lastly, he will provide some links to important program resources, and with any time left, he will address questions posed by the attendees during the broadcast. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you, everybody, for joining us today to talk about the Medicaid Interoperability Program this year. While there haven't been a ton of changes from last year to this year, there definitely are a few things that you need to be aware of, and throughout this presentation, I'll kind of highlight where those changes are as we walk through things. So let's go ahead and get started. So one of the things I did want to talk about was program eligibility. While we didn't see any changes in terms of the minimum patient volume that is necessary, that is still an important part that you have to be aware of and make sure that that your clinicians who are still participating in the program can meet those volumes each and every year. So again, they have to demonstrate that they have a minimum 30% patient volume that's attributable to encounters with Michigan Medicaid enrolled patients. There is a slightly lower threshold for pediatricians, but do note that if you do choose to use that lower threshold, it does also cut the incentive payment by a third. And as always, I like to point out that mid-level providers do not meet the program's definition of a pediatrician. So just be careful if you are in a peds office with mid-level providers, and that could cause a problem when if you group report, which I'll talk about in a moment as well. That eligibility reporting period is that continuous 90-day reporting period during which the clinician demonstrates that he or she has maintained an adequate Medicaid patient volume to be eligible. There's two different ways that you can, or two different timeframes really, that you can use to find that continuous 90-day reporting period. One of them is prior 12 months. That one is defined as the prior 365 days from the date of the EP's attestation or registration. So when you go in to relay this information to the state of Michigan, you can use that prior 12 months option, and you can look at the prior 365 days from that date when you're going in to actually attest. The other option is prior calendar year, and that one is defined as January 1st through the 31st of the prior calendar year to the program year. So for that option, prior calendar year would be the calendar year 2019 when you're attesting for this year. And then note that these options, once the attestation period opens, which is a little bit different for this year, so we don't have this dead zone issue quite yet, but once we cross into early 2021, which is normally when the attestation period opens, it can create what we call a dead zone of unusable dates. And that is because, let's say, for the example that you have on your screen there, if you were to log in and attest one of your clinicians on March 21st of next year, then the dates of 1/1/20 to 3/20/20 are neither prior 12 months nor prior calendar year. So with these two options, again, just depending on when you go into a test, if it is early next year, just be careful. We have clinicians every single year that get caught in this issue where they want to use Q1 of a calendar year, because that's when we tend to see a lot of Medicaid patients come in the office. But depending on when you log in, you might lose some of Q1 or that ability to use your Q1 dates. So just be careful of that. Individual versus group encounter, we do have that option available as well. You have those two different ways that you can determine the Medicaid patient volume. You can use individual data, so just looking at one single clinician's data to get them in the game with that 30%. You can also do group encounter data, or what we call group proxy option. That is where you are doing a single calculation and including all of the encounters for all of your clinicians in your office. We do have a potential issue. I started talking about this, I think, earlier this year as well. There's a potential issue here that we will see happen both this year and next year. And so there's a lot on here. I tried to color code it. This actual slide is also available for download in your GoToWebinar interface right now, along with the slides. There's also another resource you'll see there as well. I encourage you to grab all three of those. But the potential issue here is using the group encounter or that group proxy option and the prior 12 months option for the eligibility reporting period, it could be problematic this year. So in this fictitious example that I have on your screen, kind of you can follow along with the purple text is reflected up here in the different colors as well. In this example, this group of 2 clinicians has chosen the group encounter option for eligibility, and they chose the prior 12-month option and an eligibility date range of April 3rd to September 2nd of last year. So the first clinician comes in to attest to their 90 days of meaningful use on April 2nd, and there's no issues at all. Everything works out just great. The issue then comes in when the second clinician comes in later in the year. So, wasn't ready to attest in that same date range, using that same date range, which is perfectly acceptable. But in this instance, it actually causes an issue with the data, with that eligibility reporting data. Because if this clinician comes in to attest to their 90 days of meaningful use on September 1st, because you use that group eligibility data, that clinician is also tied to this to that first 90-day group eligibility reporting period. So with an attestation date of September 1st of this year, that eligibility date range is no longer within that prior 12-month period. So the state will work with you if you get caught up in this, but just note, there are some ways to get around it so that you don't get tripped up by this issue if you do find yourself in this boat. The solution then would be that clinicians using that group encounter data for proving eligibility both this year and next year should use the prior calendar year option instead of the prior 12 months or the prior 365 days, and choose a 90-day eligibility period that is within 2019 for this year or in 2020 for next year, to ensure that that chosen date range is applicable to all of the clinicians in the group, regardless of when they log in and actually get their meaningful use data attested to. So alternatively, you could just avoid this issue as well by not using that group, the group proxy option, and just choose the individual clinician eligibility data instead. So there's a potential issue here. There are ways around it. Again, if you do get tripped up by this, where downstream another clinician comes in and they find that the group eligibility data that was entered is no longer captured, the system is going to kick that back. But just note that the state will work with you on that if you find yourself in that boat. So there is another important thing that you need to be aware of. This is new for this year. We'll have this for this year and next year, which are the final 2 years of the program. So I have this captured right from the EP state level registration guide. I've got a link for you on the screen here. I also have this document uploaded as that other resource, one of the three resources you can download right now if you go to Webinar Interface. So from that guide, it says for program year 2020 and 21, providers must upload an Excel document that contains both their Medicaid encounters and non-Medicaid encounters. So in previous years, to prove that eligibility, you only had to provide the state with a spreadsheet that showed all of your Medicaid patients to validate that 30%. This is a new requirement from the state. They now require you to also give them your denominator proof as well. So not just the numerator proof for those Medicaid encounters, but also your denominator proof. So if you are saying you had 10,000 overall encounters, you're going to have to provide the documentation as backup for that. So for the Medicaid encounters, each encounter must include the list that you have on your screen there, the date of service, the provider NPIs, the Medicaid beneficiary ID, if you do know what that is, the date of birth, first name, last name, the payer, and the place of service code. For the non-Medicaid encounters, that additional data you now must also submit. The only difference there is that you're not going to give them that Medicaid beneficiary ID. You can look at page 11 of that guide for some screenshots, for some spreadsheet examples to give you some more information. And there's a page or two devoted to this as well in that guide, right there at page 11. So just note that that is a new requirement for this year and next year. One question we are getting quite a bit now, of course, in this in the COVID-19 times, with so many clinicians flipping over and starting to service their patients through telemedicine, is wondering, do the telemedicine encounters count in the program? And unequivocally, yes, they absolutely do. So telemedicine patient encounters within this program are treated the same as in-person encounters. There's really no difference at all. You're going to include all of those telemedicine visits or those encounters in your eligibility calculations, both on the Medicaid and non-Medicaid side. And then during those telemedicine encounters, you've got to ensure that your staff and clinicians are using the same workflows that they would use to meet the Medicaid PI measure thresholds if that patient was being seen in the office. So you need to make sure that you're still offering that patient portal to every single patient. You got to ensure that you're pushing those electronic patient education materials to the portal. You could still have to be doing that reconciliation of clinical information. You want to be hitting those patients or communicating with them through your secure messaging. Definitely be looking out for any and every opportunity to both send and receive those electronic summaries of care for the HIE measures. And so really all of those workflows across all of the Medicaid PI measures, those telemedicine encounters work the exact same. You got to ensure that while you are not seeing that patient in the office, you're still seeing them through telemedicine, through those telephones and those video chats. You got to make sure that you're keep those same workflows in place. Obviously, they're going to need to change a little bit with the patient not being in the office, but you gotta ensure that you are focusing on those telemedicine visits as well. So the Medicaid PI requirements, we are in stage 3, of course. Within stage 3, we have 8 different objectives with 20 associated measures within them. It is still a minimum 90-day reporting period. That is, again, a minimum. It can be anywhere from 90 days to 365 days. So you don't necessarily have to limit yourself to only 90 days. Depending on the clinician and their patient volume and a bunch of different factors, you actually may find that they hit the threshold by extending that beyond 90 days and reporting on, let's say, 101 days or 240, maybe the entire year to get past those thresholds. So don't limit yourself to only looking at that 90-day period. And as always, that 90-day period for the measures can and often is different from that eligibility reporting period. They're both continuous 90 days, but they do not have to be the same 90+ days. You do also, again, have to report on 6 clinically relevant ECQMs or electronic clinical quality measures. A couple of years ago, they changed the program here to match the quality payment program or MIPS requirements, where one of those 6 measures must be an outcome measure, and if no applicable outcome measure is available, then you can report on at least one high priority measure. And then if no clinically relevant outcome or high priority measures are available, then you can report on any 6 clinically relevant ECQMs. This is also new for this year. In prior years, the ECQM reporting period was a full calendar year. They have made a change for both this year and next year, these final 2 years of the program, where it is also a minimum 90-day reporting period for your clinical quality measures as well. There is a mandate, however, that we've had this now for a couple of years, where you do have to at least try to submit your quality data electronically. Slide 28, for a little bit further in this presentation, we'll touch on how you go about doing that. And if your EHR cannot generate a QRDA with the proper start and end dates, we do see this happening quite a bit right now, that the EHRs are kind of hard-coded for that year-long reporting period, and there's no way to make that change in the electronic file. You can request manual CQM entry if you find yourself in that boat. So that is important because the attestation period is actually open already for 2020. We've had quite a few clinicians already getting their 2020 meaningful use reporting period in, or their attestation in, that the system opened up to start accepting those 2020 attestations already back in April. And it will be open for nearly a year. So you've got until March 31st of next year to get your 2020 attestation in. But if you are ready to go, if you can prove your eligibility and you've hit all of the measures, and you can get your hands on a QRDA file, or at least the data for that 90-day period, you can go in right now today and get 2020 out of the way. So here are those 8 objectives. Of course, we've got the security risk assessment, objective 1. There's no thresholds involved in that. You're just going to either conduct a brand new SRA, or at the very least update a prior one. In objective 2, the electronic prescribing, really no big changes there. At least 60% of all permissible prescriptions are sent electronically. Under objective 3, that clinical decision support, there's a couple of different measures there. Really, it totals 7 different CDS rules. Measure 1 is those 5 CDS interventions that are related to 4 or more CQMs. Measure 2 is ensuring that you have enabled the functionality for drug-drug and drug-allergy interaction checks. A lot of those things you've had in place now for years if you've been participating in this program. Objective 4, CPOE, or computerized provider order entry. It's got the same 3 measures we had last year. The meds, you're looking at med orders, lab orders, and diagnostic imaging orders. At least more than 60% of those need to be sent through CPOE. Objective 5, the patient's electronic access to health information. We've got a couple of measures in here. First one is that standard patient portal measure. That's why I mentioned that you have to ensure that you are offering that patient portal to those telemedicine folks as well. We have been seeing some clinicians start to fall in their percentages on this, where perhaps they have in prior years have been easily meeting the more than 80% of patients are given their timely access to their data. But now that they've flipped to telemedicine, they're kind of forgetting about that. Maybe they're not offering that information to those patients in that timely manner. So want to make sure that you have that in place. And then the second measure is providing those patients with electronic access to their patient-specific educational materials. That is an important part. We saw that change a couple years ago or so, where the kind of handing the patient education in paper to the patient is no longer valid. It must be delivered to them electronically. Most often that is done through patient portal. So again, a very important reason why you need to ensure that you're getting those patients using their patient portal and creating those accounts. And then objective 6, coordination of care through patient engagement. We've got 3 different measures contained here. In measure 1 is the patient portal use measure that we've had for several years now, where the thresholds haven't changed, but you have to ensure that more than 5% of your patients are actually accessing their data through the patient portal. You also have the option of using an API. Again, we had that option last year as well. You have to ensure that you not only have access to the data through your patient portal, but that you have the ability at least turned on for the patients to connect to their own data through the application programming interface, or API. In the second measure, you've got to be, again, sending those secure messages to more than 5% of your patients. And then measure 3, same as we had last year, it's incorporating patient-generated health data from non-clinical settings for more than 5% of the patients as well. I actually have hyperlinks on this slide as well. If you grab the slide by your GoToWebinar interface, if you click on each one of those hyperlinks, it's going to open that objectives specification sheet that will give you a wealth of information about what is needed to meet the requirements for each one of those objectives. I'm really going to focus here, though, on the last 2 objectives. Objective 7, health information exchange, and Objective 8, public health and clinical data registry reporting. Again, because we continue to see these 2 objectives really tripping folks up. The HIE objective remains very difficult to achieve in this program. While folks are being successful in it, I know a lot of folks are not yet. And so we're going to focus kind of on that one and do a deep dive. And then same thing on the public health. Even though we've had the public health reporting in place for several years now, it still is a source of issues. And there are a few things to be aware of that have changed over the years, and especially from last year to this year with some of the registries that we have available here in Michigan. So we'll do a deep dive on that one too to kind of pick it apart. So first, Objective 7, the HIE or Health Information Exchange. So the EP, or eligible professional, is providing an electronic summary of care when they're transitioning or referring their patient to another setting of care. And then you're receiving or retrieving an electronic summary of care record upon the receipt of a transition or referral, or upon the first patient encounter with a new patient. So I think a lot of folks get tripped up there as well, and they're only looking at those incoming referrals, but those are captured in the denominator. But it goes much further than that with this measure these days, where it is also picking up any of your new patients. And you need to incorporate that summary of care information from those other providers using your EHR. So we have 3 different measures in this objective, but you only need to meet the thresholds for 2 of them to get past it and to meet the overall objective. So you could actually fall below the threshold on one of them and not get kicked out. You're still going to meet meaningful use if you fail to meet a threshold on one of them. Note that exclusions don't count, though. So if let's say you are going to attest with numerators and denominators on measures 1 and 2, but you're going to claim the exclusion on measure 3, that would be okay. But if you claim a couple of, or let's say if you claim 2 exclusions, you have to make sure that you're meeting the objective on that last one. You also, if you meet one, fail one, and exclude one, you're also not going to get past that objective. So you really do have to meet the thresholds on at least 2 of them, unless you can claim multiple exclusions. Let's say you're going to meet the objective on measure 1 and going to claim exclusions on 2 and 3. That would be okay, but just be careful if you're going to if you've got a combination of meeting thresholds, claiming exclusions, and failing. That is probably going to trip you up there. So for measure 1, it's the measure we've had for some time now. We've seen it increase in thresholds over the years, but once we've been in stage 3 now, it's remained constant. We don't expect to see any changes for next year either. So for measure 1, more than 50% of transitions of care and referrals, the EP that transitions or refers their patient to another setting of care or provider of care creates that summary of care using their EHR and then electronically exchanges that summary of care record with that next setting of care. In measure 2, it's looking at the flip side. So you are going to be looking for and incorporating those summaries of care for the patients coming to you, those transitions or referrals that are being received for and after patients. So it's new patients as well. You got to have more than 40% of those patients you have to incorporate into your EHR an electronic summary of care document. I'm gonna dive a little deeper into that one because there's some additional caveats and some due diligence, as well as an ability to actually remove patients from the denominator for Measure 2, and I'll talk about that in just a moment. Measure 3, for more than 80% of those transitions or referrals received and patient encounters in which the provider has never before encountered the patient. So again, this one for that denominator is also picking up those new patients. The EP is performing a clinical information reconciliation. You have to at least do that clinical rec on medications, medication allergies, and the current problem list. And so that is a very high bar with more than 80%. But again, the clinical information reconciliation should be just a normal course of action, some of that normal workflow that you have built in. But just note that telemedicine counts. Your EHR is going to be capturing those in your denominator. So you have to ensure that if you're doing telemedicine visits, you are doing this clinical information reconciliation on those patients as well. So you've got the numerators and denominators here, just walk through that. Again, just make sure you understand that measures 2 and 3 are also picking up all of those new patients who are new to your practice as well. There are exclusions built in for all 3 of these that you might qualify for. I actually have, you can see on your screen, a couple of them are crossed out. So measures 1 and measure 2, measure 1, the kind of main exclusion, we'll call it, is that any EP who transfers a patient to another setting or refers a patient to another provider less than 100 times during your 90-plus day reporting period. If you fall below that 100 in your denominator, you could claim the exclusion. You definitely don't have to. And honestly, if you're meeting the threshold, even though you have fewer than 100 transitions of care, while you can qualify for the exclusion, I'm not really sure why you would. If you're meeting the threshold with 1 out of 1, that's 100% performance. So go ahead and report that instead of claiming that exclusion. But definitely, if you're below that threshold of 100 and you're not meeting the threshold for the measure, that would probably be a good idea to go ahead and claim that exclusion instead. Measure 1 has a second exclusion, which does not count in Michigan. It is looking at whether the county in which you are, where your TIN is at, if it doesn't have enough broadband availability. There are no counties in Michigan that qualify for that, so don't even try claiming the second exclusion. We see that on Measure 2 as well, so that's why it's crossed out for those. There are no counties in Michigan that do not have adequate broadband availability these days. Measure 2 does have that other exclusion, though, that looks at those incoming transitions of care and referrals and patient encounters in which the provider has never before encountered the patient. If you have fewer than 100 of all of those categories during your reporting period, you could be excluded from this measure as well. And then Measure 3, any EP for whom the total transitions or referrals received, and again, those new patients as well, which the provider has never before encountered the patient. If it's fewer than 100, you could claim the exclusion on that measure. So let's circle back to Measure 2 and talk about excluding patients from the denominator calculation. So I've taken this from the specification sheet, which you can click on the hyperlink here on the slide. For the purposes of defining the cases in the denominator for Measure 2, we stated that what constitutes unavailable and therefore may be excluded from the denominator will be that an EP requested an electronic summary of care record to be sent and did not receive one, and the EP either queried at least one external source via HIE functionality and did not locate a summary of care for the patient, or the provider does not have access to HIE functionality to support such query, or confirmed that HIE functionality supporting query for summary of care documents was not operational in the provider's geographic region and not available within the EP's EHR network at the start of the EHR reporting period. So for Measure 2, you have some due diligence to do there. So if the sending clinician didn't automatically send you that electronic summary of care for their patient who they're sending to you, you need to go out, you need to reach out, you need to contact that doctor, that clinic, that provider, and request that electronic summary of care. If they do not send one to you, if they cannot send one to you, there is that second step where you have to try and find one on your own. A lot of EHRs are building this functionality right into their systems. We know some of the big players out there, like Epic, and some others are building in some functionality that you can opt into paying for that accesses these, let's call it a data lake of summaries of care. A lot of HIEs and the hospitals are sending those summaries of care to these data lakes. Our own HIE network, MyHIN, is tapping into this as well, where you can query for your patient just to see if there's a summary of care out there. So the clinician hasn't sent it to you or isn't able to, or whatever the reason, but you also have to do that due diligence to kind of find it on your own if you have that availability to do so. The state of Michigan, just like last year, has once again confirmed that a readily available, affordable statewide option to query for a summary of care document is not yet available for our state. So if the ability to query for a summary of care is not available within your EHR, the clinician can actually skip step 2 of this due diligence to locate one and remove the patient from the denominator count if the EP completes step 1 and does not receive it. However, if that functionality is available within your EHR, there's not a lot of you have opted into that, but I have come across quite a few clients that have as well. If you have opted into that, if your EHR offers it and you have access to it, you do have to use that query function, and can only remove the patient from the denominator if the summary of care remains unavailable following that query. So you definitely have to do step 1. Everybody has to do step 1 before you can remove that denominator or that patient from the denominator. Some of you have to do step 2, where you are querying that external source to try and find a summary of care for the patient. If you do not have access to that functionality, the state of Michigan is kind of letting you off the hook for step 2 for this year again. I do not know if that will remain in place for next year. Kind of check back with us when we do those webinars, and we have monthly conversations with the state of Michigan team. We work very closely with them. So if in fact that remains unavailable, I hope anyway that we'll have that flexibility next year as well. But we definitely have it this year so far. Some additional information on the HIE objective. For measure 2, a record cannot be considered incorporated if it is discarded on the reconciliation of clinical information. It is not accessible to use within the EHR. So it isn't enough to receive that summary of care for that incoming patient or that new patient. You do have to incorporate that data. CMS doesn't strictly define what incorporate means. They do kind of leave that up to you and your technology to decide on how to quote unquote incorporate. But you do have to make sure that you store it in a place anyway, that the EP could still access that information. So you don't necessarily have to download that information directly into your structured data fields. A lot of EHRs and users are hesitant to do that piece of it, and that's okay, as long as the EP still has access to that electronic summary of care that was received. For measure 3, the process may include both automated and manual reconciliation to allow the receiving EP to work with both electronic data provided with any necessary review and to work directly with the patient to reconcile their information. So it doesn't have to be electronic clinical reconciliation. It can be a very manual process. Again, you need to ensure that you're still doing this through those telemedicine visits. And so I could see that realistically being that kind of manual reconciliation where you're looking through what you have on record in your EHR with the patient and working with them to ensure that everything that's in there is accurate. And then also for measure 3, if no update is necessary, the process of reconciliation may consist of simply verifying that fact or reviewing a record received on referral and determining that there wasn't anything that needed to be reconciled. that also counts for that numerator credit. You just have to ensure that you know what to do in your EHR to give that numerator credit to say there was no clinical reconciliation needed, so that you don't get dinged in that numerator as well. And then also, non-medical staff may actually conduct that reconciliation under the direction of the EP, as long as the EP or some other credentialed medical staff is still responsible and accountable for the review of whatever was reconciled. So it doesn't have to be your clinical staff. I think it most often is, but just note that it does not have to be. Here we've got some guidance in terms of documentation. You want to ensure that year after year, as you participate in creating what we call an audit file, where you are saving all of the various elements, all of the different proof required that in case of an audit, a fair number of you are going to be audited on your 2020 attestation, and it could happen up to 6 years from now. If you do not build your audit file this year for 2020, I can almost guarantee up to 6 years from now, when the state reaches out to you and says, hey, we're going to audit your 2020, give us this information, you're probably not going to be able to find it. So I implore you to build that audit file now, grabbing those screenshots and whatever it is that you need to be able to document and substantiate the required data elements were actually there. It is not always just to have it listed on your meaningful use dashboard report. A lot of instances, you've got to take it a step further and documentation and screenshots and whatnot. And that is not just the case for the Health Information Exchange. That is the case for every one of the measures. So here we have what we are suggesting you might want to get your hands on for the Information Exchange. Again, there's a link to the specification sheets to list all the required data elements for Measure 1. Again, and then also for the exclusions, you want to have that documentation that supports that your outgoing or incoming patients and transitions of care, new patients and everything were under those thresholds. All right, let's move on to Objective 8, Public Health and Clinical Data Registry Reporting. So here, we haven't seen any changes at all with the objective, where the EP is an active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using your EHR. So as before, you have to be actively engaged with at least 2 different registries, which there are 5 different measures to choose from. You could actually report on the same measure twice. We don't see it a lot, but we definitely do see that happening, where we have clinicians that, let's say you are practicing on the border of Michigan and Ohio, and so you are seeing patients in both states, so therefore you are tapped into the immunization registry in Michigan, MICR, as well as Ohio's immunization registry. So you'd be attesting, if you're actively engaged with both of those, you could attest to Measure 1 twice and get past this objective. We also have Measure 2, syndromic surveillance reporting, Measure 3, electronic case reporting, Measure 4, public health registry reporting, which again, a lot of clinicians end up using Measure 4 twice, or even Measure 5 twice, the clinical data registry reporting. There are no exclusions to be had here necessarily, and I'll talk about that. Each one of them have exclusions, but just be careful with claiming those exclusions. You could get yourself into trouble as well, and I'll talk about that in a moment. There's no numerators and denominators. You just have to be actively engaged. So what does it mean to be actively engaged then? Again, as we've had, I think, since the beginning of the Meaningful Use program, there's 3 different options for active engagement, or 3 different definitions, and any one of these constitutes active engagement. So option 1, you have completed that registration to submit data, and that's it. It's a very low bar. But just note that you do need to ensure that you have done that within the first 60 days of your reporting period, whether it's 90 days or longer. You have to make sure that you have at least hit option 1 within the first 60 days. Otherwise, you cannot claim active engagement with that registry. Option 2 is testing and validation. So once you've registered for that, The registry is going to start working with you, and you're going to be sending them test data to ensure that what your EHR is producing, and as you begin to create that interface between the registry and your EHR, there's a lot of work involved with that. And so you find yourself in option 2. So if you're in that testing and validation, wherever you are in that process, option 2 means that you're actively engaged. And then once you get through the testing and validation, the registry is ready to start accepting production data from you. The last step, that's where you're sending that live data from day to day to the public health agency or clinical data registry. So obviously that is actively engaged as well, because you've got that system fully up and running. You are now in option 3. All 3 of those mean that you are actively engaged. Let's take a little bit deeper dive into each one of the measure options. So the first one is immunization registry reporting. Again, you're going to attest that you're in active engagement with a public health agency to submit immunization data and receive immunization forecasts. That is a very important part of this measure these days. In prior years, I think 2018 and earlier, under the earlier versions or earlier stages of meaningful use, you could have that unidirectional setup with the immunization registry where you were just sending them your information, and that would mean actively engaged. It's now a bidirectional interface that has to be live, or you have to be actively engaged for at the very least. If you are not actively engaged for a bidirectional interface with MICR, you cannot claim active engagement this year. There are in paper, there are 3 different exclusions that you could would allow you to get past this measure and move on to maybe the other ones. However, again, 2 of them do not count in our state, so you cannot claim exclusions 2 and 3. The only exclusion you can use is if you do not administer immunizations to any of the populations for which data is collected by MICR. In Michigan, again, we have MICR, and as I mentioned, you must be actively engaged for their bidirectional connections. That is called QBP, or query by parameter. Unidirectional active engagement, which is called VXU, is no longer enough to meet the program requirements. And MICR requires participants to be in production with their unidirectional feed prior to accepting registration for QBP. Last year, the state of Michigan kind of flexed the rules a little bit there, and they gave you a little bit of flexibility if you had not yet gotten to production under VXU. That is no longer the case in 2020. You have to be in production with VXU and then be at least actively engaged with MICR to get QBP up and running. Otherwise, you cannot claim to be actively engaged with the immunization registry. So that flexibility we had in 2019 is not in place for 2020. So if there are quite a few of you that have not yet reached production under VXU, just note that you've got to be working on that this year. Otherwise, you're going to find yourself in trouble, and you will not be able to claim active engagement with MICR if you have not, 1, gotten to production under VXU, and then 2, actively engaged with MICR for QBP. To begin that QBP process, you're going to send an email request to that email address on your screen right there, the MICR help. And then in response, MICR is going to provide you some instructions, and just follow those instructions, and you will be actively engaged for QBP. Syndromic surveillance reporting. This is valid for very few of you. The vast majority of EPs do not qualify for this measure, and you are kind of automatically qualified for the exclusion on it. There are, again, 3 different exclusions on paper, but 2 of them do not apply for our state, so I crossed them out. So you can only claim the exclusion for this measure if you are a clinician that is not in a category of providers whom MSSS, Michigan's Syndromic Surveillance System, will connect with. And MSSS only accepts syndromic surveillance data from hospital ERs and urgent care locations. So if you're not one of those participating in meaningful use, and you're going to automatically qualify for the exclusion. And just note that primary care offices, which have these after-hours urgent care-like services, that does not count. You have to actually be a legitimate urgent care location. So I know a lot of you kind of after hours, you kind of turn into an urgent care-like location, but that's not going to do it for you. You have to be an actual urgent care location to start working with the Michigan surveillance, syndromic surveillance system. Electronic case reporting. The EP must attest yes to being in active engagement with a PHA to submit the case reporting of those reportable conditions. In the only exclusion that again works for us here is if you do not treat or diagnose any of those reportable diseases for which the Michigan Disease Surveillance System accepts. There's some additional criteria here for the electronic case reporting that I suggest you click on those links. That first one here, the CD info, is going to tell you what those reportable conditions are that MDSS collects on. But you do also have to have the capability to submit electronic case reports in the standardized format. So a national standard has been developed for electronic case reporting, and what we've seen so far is very few of the EHRs are actually certified to that standard. You can get some more information there on the link, but the translation comes down to that if your EHR is not certified for electronic case report, use this measure. If you were to reach out to the MDSS, it's one of the first questions they're going to ask you is, what is your EHR? Because they know which EHRs have been certified for electronic case reporting. If you are not one of those EHRs, the registry is going to kick out your registration and say, sorry, even though you do have one of those reportable, you're working with one of those reportable conditions, your EHR is not certified to that standard. If you find yourself in that boat, you can just claim the exclusion on this measure. So before I get to the other ones, let's circle back and talk about specialized registries. We don't have this question as much, but in case there's some confusion out there yet, in prior stages of meaningful use, we had a measure called specialized registry reporting. If you noticed, we no longer have that under stage 3. Don't fret, each one of those specialized registries, what they call themselves specialized registries, will most likely fall under one of two categories now. They're either going to be a public health registry or they're going to be a clinical data registry. And the difference is in what type of organization is administering that. So if it is a governmental entity, that specialized registry is now a public health registry. So under modified stage 2, for instance, the MAPS, the MAPS system or the MAPS registry was a specialized registry, but because the state of Michigan manages that registry as a governmental entity, MAPS is now a public health registry. Clinical data registry captures all the rest of them, so all those non-governmental entities. So a lot of medical societies have registries out there. All of those were called specialized registries under modified stage 2, but under stage 3, they would all fall under clinical data registries instead. So the public health registry, you have to attest yes to being in active engagement with one of them. Again, there are 3 different exclusions, 2 of which don't apply in Michigan. But if the clinician practices in a jurisdiction for which no PHA is capable of accepting electronic registry transactions, then you could claim that exclusion. The other ones do not count here in our state. In Michigan, we have quite a few different registries to choose from. The state manages. We've got the MAP system, as I just mentioned, Michigan Automated Prescription System. We've got the Cancer Registry, the Birth Defects Registry, the Birth Registry, and the Newborn Screening Registry. Similar to electronic case reporting, under the Cancer Registry, if your EHR is not certified to the Cancer Registry standards, then you cannot engage with them for the Cancer Registry. And also note, this is very important for anyone who has previously been using Michigan's Dental Registry or MITRE. That registry was actually decommissioned back in June, and it can no longer be used. So it kind of lost the funding that it needed to keep going, and so it is actually shut down as of June 12th. I think all of you, if you have been engaged with MITRE, have received some sort of communication from the registry or from the state on this. But if not, just note that MITRE is no longer an active registry in Michigan, so you could not claim to be an active engagement. There is a registry nationally as well that would fall under the Public Health Registry reporting umbrella, and that is the CDC's National Healthcare Surveys Registry. A lot of you, I know, have used this one, have engaged with this one in the past. There is a change here for this year and next year. As of 2020, the CDC now requires your EHR to be certified for a particular standard. It's the Transmission to Health Agencies Healthcare Surveys standard. I've got the reference to it there on your screen. If your EHR is not certified to that standard, you can no longer be engaged with the CDC for that registry. If you are curious if your EHR is certified or not, I have the hyperlink to the Chapel website. That is the site that is managed by the Office of the National Coordinator for Health IT, that kind of manages all the certifications for the different EHRs. You can go to that website and pull up your EHR and then look for that under their certified standards, and make sure that one, that Transmission to Public Health Agencies Healthcare Surveys, is listed there. If not, you will not be able to be engaged this year with the CDC, and that's the same for next year too. Clinical data registry reporting. This one does have all the exclusions in place yet. I didn't cross any of them out. But here I just want to point out that jurisdiction is often national with these CDRs. So if just keep that in mind, that these specialty societies and whatnot, they're always national in scope. So if you're in the nation, you're part of that jurisdiction. One example is like the Prime Registry. There are a lot of them out there. So for some additional examples, this is not a comprehensive list of them, but I do find this being a good one. If you're looking for one of these clinical data registries, you can click on the National Institutes of Health list registries. They've got a pretty lengthy list there of potential registries that might apply to you. To be valid for use, so not every registry is valid to be used within the EHR. There are 3 different criteria that the registry must have in place, one of which is they must publicly declare readiness to accept electronic data at least 6 months prior to the start of the program and be able to accept electronic submissions. So manual data entry into a website does not count. What we're trying to do here is connect your EHR to that registry. So just logging into a website and manually typing in numbers and data, that is not enough. It's not sophisticated enough. It's got to be able to interface with your EHR. It also must be able to support the registration, onboarding, and production processes. Kind of in that same vein, you've got to be connecting that EHR to the registry. And then the registry also has to be able to provide documentation as evidence of active engagement. So there is a potential issue under stage 3 with those former specialized registries. There's a lot of kind of governmental gobbledygook here, and I'll try to translate it for you. Why don't we just jump down to the translations that are in blue on your screen here. So through the final rules, and you'll see this data reflected, or this information reflected in the specification sheets for the public health objective as well. Again, this applies to both the Medicaid and the MIPS side as well. For Measure 4, so for the public health registry, if the registry is a PHR, does not use a standardized method or language for the transmission of data, and you did not attest to being in active engagement option 3, production in a prior program year, it cannot be used in the Medicaid PI program to meet stage 3 requirements. Under Measure 5, the way this all translates to is if the registry is a CDR and does not use a standardized method or language for the transmission of data, it cannot be used in the program either. So by a standardized method or language, what we're talking about is there's a lot of different options there as well, but it needs to be transmitting, let's say, through HL7 via a QRDA file. There's some others listed as well that would be standardized method. So if the registry is not sophisticated enough, let's say you are just uploading an Excel spreadsheet, that is not one of those standardized methods or language. The registry has to be sophisticated enough and have that technological capability to be accepting that data through one of those standardized methods like HL7 or QRDA or CCDA or some of those standards. If it's a lower level, it cannot be used here. The next slide, and this is another handout I have uploaded to the GoToWebinar interface as well, is this decision tree that we worked with the state of Michigan to create. And this is what they're using to kind of validate those registries. So we start at the top here, and we really look at who administers the registry. If it's one of those governmental entities, it's going to fall under the PHR bucket. We're going to ask, are specified standards used for the transmission of data? If the answer is yes, you're good to go. You can qualify under stage 3 with that one. If the answer is no, the next question is, has the EP achieved production status in a prior program attestation? If the answer is yes to that, we're good to go. If the answer is no, you cannot engage with that registry for stage 3 and claim active engagement. You have not met those requirements. So just one question on the other side. So if it's one of those clinical data registries, they ask that same first question: are specified standards used for data transmission? If the answer is no, it cannot be used. If the answer is yes, it can be used under stage 3. Again, kind of circling back to that audit guidance, you just want to ensure that you have that active engagement letter from the registry or some other type of proof that you can substantiate that you were in whatever option of active engagement, option 1, 2, or 3 with that registry during your reporting period. Some documentation for the state-sponsored registries. You can get that through the HESTER system, the Michigan Health System Testing Repository. I've got the link there at the bottom of your screen. That's the state's system to kind of manage all of their state-sponsored registries. That is also where you would go to get that active engagement letter to substantiate that you were in fact actively engaged with that registry. This just summarizes the list of state systems. The MITRE you see is crossed out because that one, as I already mentioned, was decommissioned, but there are hyperlinks to each one of those state registries there as well. So what must a program participant do prior to claiming a public health measure exclusion? So you can't just exclude because you want to. You've got to meet these minimum requirements. So there's some due diligence you have to do here before you can claim that exclusion. You have to determine if the registries that are being offered by a public health agency, like the state of Michigan, are in their jurisdiction, which may be state or national level, depending on the registry, so be very careful about that, are relevant to the provider's scope of practice. So the prior slide had the state options. The one national example is the CDC. There could be other national PHAs out there as well. If it's clinically relevant to you and you are technologically capable of connecting with them, you must achieve active engagement with that registry. You cannot claim the exclusion. Next, you have to determine if a medical society with which the provider is affiliated endorses or sponsors a valid registry. So again, you can look if it's clinically relevant and technologically capable, you're going to achieve active engagement with that registry. If you go through steps 1 and steps 2 and you cannot make a valid public health registry determination, then you can claim 1 or perhaps 2 exclusions and kind of get past this particular objective. However, claiming those exclusions don't really work unless you can claim enough of them. So this is different from the MIPS program, which actually counts those exclusions towards your 2 active engagements. The Medicaid PI program has never and will never count those exclusions unless you have enough of them. So I kind of have the language here on your screen. An exclusion for measure does not count toward the total of 2 measures. Instead, in order to meet this objective, the EP needs to meet 2 of the total number of measures available to them. If the EP qualifies for multiple exclusions and the remaining number of available measures is less than 2, the EP can meet the objective by meeting all of the remaining available measures and claiming the applicable exclusions. So, and then available measures, of course, are the ones for which the EP does not qualify for an exclusion. So just be careful on that, the Medicaid PI program works differently with exclusions in this objective than the MIPS program. So finally, we'll talk about that electronic requirement to submit your data. There's a system called Skimmer. I think we're into our 3rd year now with this program, but I do want to just point out again that this year, you are required to at least try to submit your electronic clinical quality measures through the Skimmer system. The Skimmer, what it does, it's a MyHIN service. It's going to validate that data, and then it just passes that file on to the state's attestation system that's within CHAMPS. It's called EMIP. It's this attempt to phase out that manual quality data submission process. To submit your 2020 CQM data, the clinician needs to get their hands on what's called a QRDA3 file from their EHR. It can be either individual or group level. It doesn't matter. That is not tied to how you are submitting your eligibility data. So if you did group level eligibility data, you could still send individual CQM data. Those two things are not linked. You could also get your eligibility at the individual level and submit a group level QRDA3 to get your ECQMs in. So those are not linked together. The link is there to register and submit those files. And again, as I mentioned, you have to at least try to do this. The state does give you some flexibility. They will work with you if for some reason you cannot submit through the Skimmer system, but they're going to require that you at least try to do it or give them some reason on why that's not possible for you. If you cannot get those ECQM submitted through Skimmer, you're going to send an email to the address on your screen there. You're going to explain why the EPO group is requesting manual CQM entry. You're going to give them your CERT ID number. Again, that's going to link you to the Chapel system there to get that certified EHR ID number. And then you're going to give them some information that explains why you couldn't do it. And then as we've had last year, again this year, if your EHR is charging for that data file, there are quite a few of them that like to nickel and dime their clients to death. If you're in one of those and you don't want to pay for that file just to submit it to the state, that would be an acceptable reason for requesting that manual entry option as well. All right, we're getting kind of to the end of the presentation. I've got a wealth of different resources. A lot of the stuff I have touched on. That first link to the MCEDA Stage 3 measure tip sheets, those are just some additional tip sheets that we've created for you to kind of pull out some of the relevant information that's important for the different measures. We've got links to the different websites, including the state of Michigan's website here. This healthit.org site is a very helpful one. Again, specification sheets, the registration guide, the EP guide, a wealth of good information here, as well as that Skimmer website again too. So with that, that concludes the presentation. Hopefully you got some good information, especially focusing on what kind of those handful of changes that have happened. And I think some of you were probably just very surprised to learn that those telemedicine visits do count across both eligibility and the measures. I am open to any questions. I think for possibly the first time ever, I didn't get any submitted during the presentation. If you have questions following this presentation, just note that we are always here to help you. You can access us through the MCEDA website. You've got our phone number right there. That is also my personal email and my desk office phone too. We love answering your questions. We are here being funded by the state of Michigan to help you become meaningful users. You are not alone in this trek. We are happy to help you. The state of Michigan is still funding us as well to be out there helping you guys. So for the low price of only $200 per clinician per program year or per attestation, that's going to get one of my very talented colleagues to be right there working side by side with you, or in this COVID world, maybe virtually, kind of walking you through every step of this process. So that is a very good value. It remains probably one of the best values out there. So the state of Michigan wants you to be a meaningful user, and they are funding us to be out there helping you get there. So if there's anything we can do to assist you, please do not hesitate to reach out to us. You can ask us a question if that's all you got. If you really want that help, which a lot of you still need it, please link up with us, partner with us. We'll get one of our colleagues right there working with you, and we're going to work tirelessly to make sure that you achieve the meaningful use measures this year. So with that, I thank you very much for your time today. I look forward to seeing you on future webinars. I look forward to assisting you in the Meaningful Use program. And I hope you have a wonderful day. Thanks.